We track a sequential inflammatory event. A severe immune response originates in the outer left ankle, then ignites a secondary flare across the right metatarsals. When patients experience an acute gout attack, they often assume the severe pain is caused by uric acid suddenly crystallizing inside the joint overnight. The clinical reality is different. Monosodium urate deposits function as inert, microscopic debris. They can sit quietly inside the joint lining, cartilage surfaces, and nearby tendon sheets for years without causing a single moment of pain. An attack does not mean new crystals suddenly formed. It means the patient's system crossed an immunological threshold, triggering an innate cellular alarm to react to a hazard that was already there. By tracking the progression of this specific left-to-right sequential flare, we will identify the biomechanical triggers that cascade from one limb to another and contrast the distinct mechanisms of two frontline pharmacological interventions. Understanding a gout flare requires analyzing the body as an interconnected system of shifting physical loads and immunological tripwires, rather than a single isolated joint failure. In the days leading up to the initial flare, several metabolic stressors converged. High heat, heavy sweating, and imperfect net hydration began to tax the patient's physiological baseline. This metabolic strain was compounded by poor sleep and prolonged periods of high nervous system activation. This chart tracks the resulting systemic vulnerabilities. As hydration and sleep metrics decline and stress increases, kidney urate clearance is temporarily reduced. These lines sharply converge, creating a fluctuating urate concentration that pushes the system across the flare threshold. A patient might later return a normal serum uric acid reading of 5.5, but serum urate can naturally fall during an acute flare. That later normal result does not exclude an earlier spike, nor does it exclude the presence of deposits already in the tissues. The attack initiates because the systemic physiological environment lost its ability to tolerate had likely made this joint a preferred storage site for long-term urate deposits. The cascade starts when a macrophage physically encounters exposed urate debris. It sounds an immediate cellular alarm, releasing a rapid burst of glowing particulate signals. The macrophage treats the crystal as dangerous debris. This detection activates an internal cellular complex called the NLRP3 inflammasome. Once activated, the inflammasome produces potent inflammatory signals, specifically interleukin-1 beta. This signal calls in a massive influx of neutrophils to flood the area. This is strictly an innate white blood cell response. Red blood cells are not attacking the joint. Their main role remains carrying oxygen. As the neutrophils swarm the outer ankle, they generate extreme heat and disabling pain. The resulting swelling perfectly mimics the sensation of a newly torn ligament. On this anatomical map, pain expands from the outer ankle, rapidly spreading inward. The original crystals do not move. Instead, inflammatory fluid and immune cells permeate connected tissue pathways. Rising internal fluid pressure highly sensitizes nearby nerves, making even the pull of gravity agonizing. The migrating sensation of a severe gout attack is the biological alarm radiating through fluid pathways, not the movement of the crystalline hazard itself. By the time pharmacological intervention occurs, the patient is unable to bear weight, the joint exhibits intense heat, and the neutrophil response is fully established. Corticosteroids like prednisone are introduced. Prednisone is not administered to destroy crystals. It is deployed to issue a broad systemic command to halt the immune operation. Prednisone enters cells throughout the body, altering inflammatory gene signaling. When the molecules bind within the nucleus, the output arrows immediately shrink, halting inflammatory signals. This genetic command drastically reduces cytokine production, suppresses macrophage activation, and stops continuous neutrophil recruitment, halting vascular leakage. Even after the intense warmth and throbbing stop, the joint will still feel mechanically weak and moderately painful. This residual discomfort stems from lingering inflammatory fluid, irritated tendons, capsular sensitivity, and muscle guarding developed after days of limping. Prednisone successfully shuts down the biological recruitment pipeline. It leaves behind a dormant battlefield where the physical crystals and collateral tissue damage remain entirely intact. As the left ankle enters its recovery phase, we have to examine the patient's biomechanics.
To protect the injured left ankle, the patient alters their gait. This compensation entirely shifts their downward weight load directly onto the right forefoot metatarsals. This right forefoot location likely harbored its own old, locally quiet urate deposits from previous metabolic cycles. Over a period of nearly 2 weeks, the broad systemic suppression of the prednisone naturally wears off. The immunological brake is released, while the body is still in a flare-prone state. The combination of released immune suppression and localized mechanical trauma exposes a dormant crystal in the right foot. A local macrophage detects the exposed debris, the alarm restarts in this new location, and a fresh neutrophil response begins. Multi-joint sequential gout is not an inflammatory infection traveling through the blood. It is a biomechanical chain reaction, where protecting one joint critically overloads another. Because the patient recognizes the symptoms, the right forefoot flare is caught much earlier in its cycle, allowing for a different frontline intervention. This diagram maps colchicin's cellular mechanism. The drug binds directly to tubulin inside neutrophils, wedging between the individual tubulin building blocks. This specific binding disrupts the assembly of microtubules. Without them, the neutrophils' transport and movement systems are completely paralyzed. This paralysis physically prevents the neutrophils from migrating toward the right foot crystals. They lose the mechanical ability to organize and attack or engulf the urate material. Where prednisone broadly silenced the genetic alarm across the whole body, early colchicine acts as a targeted mechanical saboteur. It destroys the transit infrastructure of the immune cells before they can establish a second full-scale battlefield. We can now evaluate the concurrent status of these two joints, which sit in distinct physiological states. In the left ankle, the major immune attack is suppressed. Residual inflammatory fluid is reabsorbing, and damaged nerves are gradually repairing. In the right forefoot, early intervention plateaued the inflammation. Neutrophil recruitment was halted before reaching full scale, though localized mechanical tenderness remains. But the unifying clinical reality for both joints is the same. Despite successful acute pharmacological interventions, the underlying crystal burden remains entirely unchanged. The acute symptoms resolve, but the fundamental microscopic physical hazards quietly remain embedded throughout the patient's connective tissues. A gout flare is a systemic cascade that can be actively managed by precise cellular inhibition, but true resolution requires permanently altering the long-term metabolic environment to dissolve the hidden threshold hazard.